Okay, let's dive in. Welcome everyone to the deep dive. This is where we take source material today. It's a specific study guide tab focusing purely on pharmaceuticals and really pull it apart for you.
Exactly. We're looking at the key medications covered here. What are they actually for? How do they work? Their mechanism of action, or MOA.
And maybe most importantly, what are the absolutely critical things you need to know?
Yeah, things like side effects, key teaching points, maybe warning signs, stuff that matters whether you take these meds, know someone who does, or you're just curious about how they work.
So based on this particular source, we're focusing on drugs for respiratory issues, blood pressure management, and anticoagulation, preventing clots.
That's the plan. Ready to jump in.
Let's do it. Respiratory first. Prednisone is where this material starts.
Yes, prednisone,
Yeah.
a common one. It's a systemic corticosteroid.
Systemic meaning it affects the whole body, right? Not just inhaled into the lungs.
Precisely. And its main MOA, according to the source, is really potent reduction of airway inflammation and swelling. It calms things down significantly.
And the use cases described are typically short bursts, like 3 to 10 days.
Yeah, often for poorly controlled asthma or during a moderate or severe flare-up and exacerbation. The idea is to stop it getting worse, speed up recovery, and hopefully prevent a quick relapse.
It also mentions use in COPD.
It does for improving symptoms.
Yeah.
But, and this is a key point from the source, it doesn't actually slow down the disease progression in COPD. That's important.
Just symptom relief there, okay?
Yeah.
And being systemic means more potential side effects to watch for.
Definitely. The list in this source is pretty extensive. Things like blood glucose issues, so sugar levels can go up, increased appetite, fluid retention, weight gain.
Mood changes too.
Mood changes, yeah. Hypertension, peptic ulcers, even insomnia.
Wow, okay. The insomnia tip is useful. Take the last dose before 2 p.m. if possible.
Right. And you always have to consider other health problems, comorbidities that prednisone might aggravate.
Plus, that warning about long-term oral use in COPD causing steroid myopathy, muscle weakness.
That's a serious consideration for long-term therapy, absolutely.
Okay, so that's the big gun, systemically. What about the quick relief inhalers mentioned, albuterol and ipratropium?
Albuterol, probably the most famous rescue inhaler. It's a SABA short-acting beta agonist.
Short-acting, quick relief, and it works how?
It relaxes the smooth muscle in your airways, binds to beta-2 receptors, so it opens things up quickly when you have that acute bronchoconstriction, that sudden tightness or wheezing.
And the source makes a really strong point here. If you find yourself needing albuterol more and more often.
That's a huge red flag.
Yeah.
It means your underlying asthma isn't well controlled. Your long-term medication likely needs adjusting. It's not just about using the rescue inhaler, it's a signal.
Got it. What about side effects from albuterol itself?
You can get tachycardia, a fast heart rate, muscle tremor, sometimes low potassium, headache, maybe hyperglycemia, so high blood sugar.
But fewer systemic effects because it's inhaled, generally.
Generally, yes, compared to taking it orally. But the source still flags caution for people with existing cardiovascular disease, especially older adults. Those heart effects can still happen.
Makes sense. What about ipratropium then? That's the other quick relief one mentioned.
Right, ipratropium. It's an anticholinergic, different mechanism. It blocks certain nerve signals that tighten airways and might help reduce mucus a bit too. Also used for acute bronchospasm.
How does it differ from albuterol in practice, based on this source?
Well, it notes that ipratropium doesn't really block exercise-induced asthma symptoms, and it's not typically used by itself for long-term asthma management.
Okay. Side effects, more dryness.
Yeah, dry mouth, dry secretions, pretty typical for anticholinergics. Keep fluids up. Interestingly, the source says it can sometimes increase wheezing in a few people.
Huh. And you need to check for allergies, like soy or peanuts.
Yes, hypersensitivity to atropine, soybeans, peanuts, and also pre-existing conditions like glaucoma or issues with the prostate like prostatic hypertrophy. Those are contraindications or cautions with this class.
All right, so moving from rescue inhalers to the long-term control side. The source talks about combination inhalers like Symbicort.
Right. Symbicort combines two things, an ICS, an inhaled corticosteroid, for inflammation.
Like a localized anti-inflammatory, unlike the prednisone.
Exactly. And a LABA, a long-acting beta agonist, for keeping the airways open longer.
The ICS component is described as the most potent anti-inflammatory for asthma here. Does a lot at the cellular level.
Yeah, reduces airway hyperresponsiveness, blocks allergen responses, calms inflammation, leads to better symptoms, better lung function, less breathing variability over time.
And the Albay part used with the ICS, that gives the sustained bronchodilation.
Correct. Great for long-term control, particularly nighttime symptoms. Also good for preventing exercise-induced asthma. Names like salmeterol and formoterol are mentioned. They keep airways relaxed for at least 12 hours.
This seems like a good place to talk about general inhaler technique, which the source covers. Super important.
Absolutely critical. Doesn't matter how good the drug is if you don't get it into your lungs properly.
First big one, especially for any inhaler with an ICS, rinse your mouth after use.
Yes. Rinse with water and spit it out. Don't swallow. This prevents oral thrush, that fungal infection.
And using a spacer device with the puffer type inhalers, the PMDIs?
Highly recommended if technique is tricky. It helps the medicine get deeper into the lungs, less stuck in the throat. Also cuts down thrush risk.
The source details the PMDI steps pretty well. Take off the cap, hold it upright, shake it.
Breathe out fully first, then slow deep breath in while you press the canister.
Right, either with the mouthpiece in your mouth or just in front. Then hold that breath for ideally up to 10 seconds.
Breathe out slowly. And if you need a second puff, wait about a minute.
And the other type, DPIs, dry powder inhalers. They work differently.
Totally different. With DPIs, you provide the force. You need a quick, deep breath in to pull the powder out.
And the crucial mistake to avoid.
Don't breathe out into the device after you've loaded the dose. You'll blow the medicine away.
Good tip. And cleaning the mouthpiece regularly, regardless of type.
Simple hygiene. Keeps it working well. These details really matter for effectiveness.
Okay, let's pivot. From lungs to circulation. Anticoagulants, blood thinners.
Right. And the key goal here, as the source states, is preventing clots from forming or getting bigger. They don't usually dissolve existing ones.
First one discussed is warfarin, brand name Coumadin.
An oral anticoagulant. Its MOA is interesting. It messes with a liver enzyme needed to actually make certain clotting factors. Factors 2, 7, 9X, and X.
How does it do that?
By interfering with vitamin K recycling, which the liver needs for that synthesis process.
And the source highlights a key implication of this. The effect is delayed, right?
Massively delayed, because it stops the creation of new factors, not the function of existing ones. It can take up to 5 days to reach its full anticoagulant effect.
Which explains why monitoring is so important, those regular blood tests.
Exactly. PT-INR tests. INR stands for International Normalized Ratio. It standardizes the clotting time measurement.
Normal INR is low, like 0.8 to 1.1.
Around there, yeah. But on warfarin, the target therapeutic range is usually higher, like 2.0 to 3.0, much higher. And the bleeding risk goes way up.
And that delay also explains bridging. Starting warfarin with something faster acting, like heparin.
Precisely. You use heparin to provide immediate anticoagulation while you wait for the warfarin to kick in and the INR to get into that target range. The source mentions long-term therapy is often over 3 months.
What if the INR gets too high or there's major bleeding? Is there an antidote?
Yes, the reversal agent for warfarin is vitamin K.
Okay. The patient teaching section for warfarin in this source is huge. Let's hit the main points.
Number 1, be consistent with vitamin K intake. Green leafy vegetables are the classic example. Don't suddenly start eating tons more or cutting way back. Keep it steady.
Because that affects the INR directly.
Good time. And then monitor constantly for bleeding. Report any signs immediately.
Like what? The source lists quite a few.
Black, Tory stools melena, blood and urine hematuria, vomiting blood hematemesis, any unusual or easy bruising, changes in mental status. That could be brain bleeding.
Abdominal pain, bleeding gums, nosebleeds, rectal bleeding. Basically anything unusual.
Anything. Take it at the same time daily. Avoid alcohol. And crucially, talk to your doctor about everything else you take.
Even over-the-counter stuff.
Especially things like aspirin, ibuprofen, or other NSAIDs, even St. John's wort. Tons of interactions that can throw off your INR.
Wear a medical ID. Keep those blood test appointments. Soft toothbrush, electric razor maybe?
Good points.
Yeah.
Call precautions are important too because a fall could cause serious bleeding.
Okay, what about the injectable anticoagulants mentioned, heparin and enoxaparin?
Right. Heparin, the unfractionated kind, can be given subcutaneously under the skin or IV.
And the IV route needs that frequent monitoring, PTT or CAPT tests.
Yeah, partial thromboplastin time. You're aiming for a level usually 1.5 to 2.5 times the normal control value. The source notes drawing the blood in a blue top tube about an hour before the next dose for accurate timing.
And there's a specific risk with heparin, HIT.
Heparin-induced thrombocytopenia. It's a serious reaction where platelet counts drop dangerously low. If that happens, or for major bleeding, the reversal agent is protamine sulfate.
And we mentioned heparin is used for bridging with warfarin. Still need to watch for leading signs, of course.
Always. Now, enoxaparin, brand name Levinox, is a low molecular weight heparin, or LMWH.
That's given subcutaneously too.
Yes. And the monitoring is generally simpler than with unfractionated heparin. Usually involves checking things like complete blood count, CBC, platelets, maybe hemoglobin and hematocrit, H&H.
Any specific injection advice here?
Yeah, the source specifically says do not rub the injection site afterwards, helps minimize bruising and hematoma formation at the site, and again, monitor for bleeding.
Okay, makes sense. We've covered lungs, we've covered clotting. Final category from this source, blood pressure and cardiac meds.
Managing hypertension, supporting the heart. Let's start with diuretics.
The water pills. This material looks at loop diuretics, bumetanide, furosemide, and a thiazide type, hydrochlorothiazide.
The general idea, their MOA, is they make your kidneys excrete more sodium, chloride, and water. By blocking reabsorption in the kidney tubules, this lowers blood volume and thus blood pressure. Also causes some weight loss, initially due to fluid loss.
Side effects across the board seem to include dehydration risk and possible high blood sugar.
Yes, but the really critical risk highlighted is electrolyte imbalance. These drugs flush out electrolytes.
So you need to monitor potassium, sodium, magnesium, maybe calcium, uric acid.
All of those, plus blood glucose. Patients need to know the symptoms of imbalance, things like palpitations, muscle cramps or weakness, headache, GI upset, and report them.
Okay, let's look at the loops first. Bumetanide and furosemide, described as very potent.
Very potent, yes.
Yeah.
And short-acting, short half-life. Often need multiple doses a day. They can cause dehydration pretty quickly if you're not careful.
Uses.
Bumetanide is often preferred in symptomatic heart failure or significant chronic kidney disease. Furosemide, often called Lasix, is super common in hospitals for acute fluid overload. Both carry a significant risk of hypokalemia, low potassium.
And hydrochlorothiazide, or HCTZ, that's the thiazide, often a first-line choice for hypertension.
Yeah, especially noted here for African American and Hispanic populations. It works slightly differently in the distal tubule of the kidney.
And the source says it's the most likely of these to cause low potassium, magnesium, and sodium.
That's what the material states, yes. And a key contraindication, because it can reduce uric acid elimination, it's generally not used in people with gout.
Why is it often preferred outpatient compared to loops then?
Longer half-life, usually just once-a-day dosing. And it's less potent, so maybe a bit less risk of sudden, severe dehydration. Easier to manage day-to-day for many.
But still need caution in diabetics.
Yes, associated with some increased insulin resistance, potential lipid issues, and that gout risk we mentioned.
Okay, moving on. ACE inhibitors. Lisinopril is the example here.
Right. ACE stands for angiotensin-converting enzyme. These drugs inhibit that enzyme.
Which stops angiotensin inverting to angiotensin II.
Exactly. And angiotensin II is a potent vasoconstrictor. So blocking its formation leads to vasodilation, wider blood vessels. That lowers peripheral vascular resistance, dropping blood pressure.
Any other effects?
A mild secondary diuretic effect, too. But importantly, the source notes it doesn't typically increase heart rate or the force of contraction like some other heart meds might.
Key side effects mentioned. There's that cough.
The infamous ACE inhibitor cough. Dry, non-productive. It's thought to be related to preventing the breakdown of another substance, bradykinin.
And potassium issues again.
Hyperkalemia, high potassium, because less angiotensin II means less aldosterone, a hormone that normally helps excrete potassium.
And the rare but serious one, angioedema.
Yes, severe swelling, potentially life-threatening if it affects the airway. Needs immediate attention. Monitoring includes sodium, potassium, kidney function via creatinine, and urine output.
Next up, beta blockers. Metoprolol and atenolol are listed as cardioselective.
Cardioselective means they primarily target beta-1 receptors, which are mostly found in the heart.
And blocking those receptors does what?
Slows the heart rate, reduces the force of contraction, slows down electrical conduction through the AV node. All of this reduces the heart's workload and its oxygen demand. Good for angina, post-MI, sometimes heart failure, and blood pressure.
Side effects. The list seems fairly broad.
Can include bradycardia, slow heart rate, hypotension, low blood pressure, feeling tired or lethargic, GI upset, potentially worsening heart failure in some, depression, even impotence. Bronchospasm is less likely with cardioselective ones, but still possible.
And critical contraindications mentioned, systolic BP below 90 or heart rate below 60.
Absolutely should not be given in those situations.
And a huge teaching point. Don't stop them suddenly.
Never. Abrupt withdrawal can cause rebound effects like worsening angina or even trigger a heart attack. They must be tapered off slowly under guidance.
Also need to monitor glucose in diabetics.
Yes, because beta blockers can mask some of the warning signs of hypoglycemia, like rapid heartbeat. And being cardioselective makes them generally preferred over older non-selective types if someone also has asthma or COPD.
The source adds a note about metoprolol, specifically caution in severe PAD and possibility of weight gain.
Little details, but important ones.
Last one in this cardiac section, cilostazol,
Right. This one's described as a phosphodiesterase III inhibitor.
MOA.
It causes direct vasodilation, widening blood vessels, and also inhibits platelet aggregation, makes platelets less sticky.
And its main use is for peripheral artery disease.
Exactly. To improve walking distance and reduce that claudication pain some people get with PAD. Takes a few weeks to see benefits, typically 4 to 6 weeks according to the source.
But a really important contraindication here.
Huge one. Absolutely cannot be used in patients with a history of heart failure. That's a black box warning level contraindication.
Wow. Okay, so that connection is vital to know.
Definitely. It really highlights how interconnected things are.
So stepping back, we've really unpacked this specific pharma tab: respiratory, anticoagulants, BP, and cardiac meds.
And hopefully, by going through the MOAs, the uses, the side effects, those crucial teaching points, you, the listener, feel a bit more equipped.
Yeah, equipped to understand maybe why certain meds are chosen, what to look out for, why those monitoring tests are needed.
It helps connect the dots, right? Between the drug name and what it's actually doing in the body, both the good and the potentially problematic. Why you need to rinse after an inhaler, or watch your leafy greens with warfarin, or report dizziness with a BP med.
And I think a final thought, drawing just from this material we've discussed, it really underscores the complexity.
Absolutely. Think about how these drugs interact with very specific pathways, clotting factors, electrolyte channels, enzyme conversions, receptor sites. It's intricate.
And it highlights that constant need for precision, for careful monitoring, for adherence. These aren't things to be taken lightly.
Not at all. They are powerful tools, and understanding the details, like the ones in this source material, is key to using them safely and getting the best results. It's about appreciating both the potential and the risks.
A great point to end on. That brings us to the close of this deep dive into this pharmaceuticals study guide tab. Thank you so much for joining us.
We really hope breaking down the source materials has been helpful, maybe sparked some more curiosity or clarified some things for you.
Definitely. Keep exploring, keep asking questions based on what you've learned. Until next time.
Stay informed and take care.